Good afternoon, everybody, or good morning if you're on the West Coast. Hi, this is Mark Lynn with Healthcare Business Specialist in Chattanooga. This is the RHC Billing 101 session. I'd like to thank Azalea Health for sponsoring this particular session of our Lunch and Learns. And this will be the first of the billing sessions that we'll go through. This is my contact information. If you need to get a hold of me, Danny Gilbert, our partner here, is going to also be on the line. She'll be handling questions and may help me out with the webinar as we go through as well. There's her contact information. What Healthcare Business Specialist does is we prepare Medicare cost reports, program evaluations, work on emergency preparedness, help people become RHCs. And if you're in Tennessee, we do TennCare quarterly reports for you as well. If you're not a member of the RHC Information Exchange Group, we would like for you to join that. There's about 3,400 members so far, and it's very useful. It's very easy for me to push information out to you, and it's very easy for you to ask questions and get information from your peers, especially about billing. If you have questions, go ahead and type those into the question box there. We will try to address them at the end of the session. I have I think about 45 minutes of material for you today. This will mostly be just a pre-test to get you ready for to see where your knowledge base is, and go ahead and start getting out a piece of paper and number it from 1 to 18. We're going to have some questions. And we'll see how you do on your answering these questions. The information is current as of today. We will talk about Medicare rules. We really will not talk about Medicaid in any of these sessions. Medicaid is different in every state. I know we've gotten a lot of questions already about how do you do crossovers in Wyoming? And I don't know how you do Medicare, Medicaid crossovers, or how to bill Medicaid in Wyoming. That is not in my skill set. So, and it's just impossible to know 50 different states, 50 different ways that Medicaid does things. And in each state, there's probably 5 MCOs that does it a little bit different. So we'll be dealing with Medicare on here. So if you're a pediatric office and you want to learn about pediatric billing, this is probably not the place to be. And the session is being recorded, so just so you know that. Here's the coming up webinars here. This is where we are today. Amanda Dennison from Blue & Company will be doing one next week. That's our 201 session. Douglas Swartz from Azalea Health, which he'll be doing our 301 session. And then Charles will be back doing the 401 session, which will be a lot of billing examples. I think Charles was telling me he had a ton of billing examples that he wanted to go through. And then the PRF funds and bad debts, Jordan Olson, Scott Murdy, and Trent Jackson from Kraft Brothers will be doing that session there. And then Danny will be doing one on TennCare quarterly reporting. If you're from Tennessee, that one will be very valuable to you. If you're not from Tennessee, you're not going to be interested in that. So that's just for Tennessee people. Do become a certified rural health clinic professional. I am one. Danny is one. It's a great course. It's by the National Association of Rural Health Clinics, the NARHC Academy. Right now, you can register for it, and the test will be coming up very soon. So you want to do that. Registration closes February 28th. This will be a great credential for you as you're getting into RHC billing. This session today is designed for brand new people. You don't have to know anything about RHCs. That's why we're doing this session, to give you a background for that. If you've never taken this 2-day course with ArchPro Coding, Gary Lucas, John Burns, and that group there, they do a great job. Both Danny and I have taken this course, and it's really good. You can get credentials from this as well. You can be a certified RHCBS. I think it's 100 questions that you have to take. You have 24 hours to finish them. I never did take the test. I should have taken the test, but I never did. I guess I'll put that on my to-do list. I'll go back and do that. But those are some resources just to get you started. Let's go into the actual pre-test of how to bill rural health clinics. And first question is, billing and coding are the same thing, true or false? I'll give you about 5 or 10 seconds to sort of think about what you think that answer is. And I'm going to move on to what the answer is right now. So write down your answer now. And the answer is false. Billing and coding is completely different. And that's not completely different, but it's a lot different and people get confused on this because coding, you're going to use CPT codes. They're done by the AMA. They copyright that, so they're very strict about their use. It's basically, what did you do? And then HCPCS codes, they're sort of similar, but they're different. They're set up by CMS, and they're used for billing. They tell you what you did and also what supplies you used. And then there's also what's called ICD-10 codes, and there's several groups involved in that: AMA, AHA, CMS, and NCHS. That's why did you do that particular service. So those are the three different things. But coding really is designed to describe exactly what you did to that patient, while billing can be different from that in that different payers have different rules. And what will happen is, let's use the example here. For RHC, we could do a 99213 via telehealth, but our billing guidelines say we convert that to a code G2025 when we bill it to Medicare. There'll be certain modifiers that we will use to do that. So that is the difference between coding and billing. And sometimes there's always a push and a pull between the coders and the billers. And they can both be right. They can have different codes and be correct on that. So typically you want the responsibility of coding to be done by your physicians, nurse practitioners, PAs, any type of provider, and your coders to tell exactly what they did. And then your billers, office managers, those types of people should be looking that over and making sure they're converted correctly to bill whatever payer it is. And that's what's so confusing about it is every payer has a different way of doing it. They have different codes, and that conversion from coding, which will pretty much everything will be the same, to billing, which will be completely different depending on what payer, what they request for. So how many got that first one correct? Probably most of you got that one right. Next one is rural health clinic status directly impacts payments from the following: A, Medicare; B, Medicaid; C, all payers; or D, just Medicare and Medicaid. And I'll give you just a couple minutes here to lock in your answers here. And the proper answer is just Medicare and just Medicaid. That will be the only payers where you're going to get a different reimbursement from that. Like I was saying before, the payers, the other payers, we always call it follow the golden rule. He who has the gold makes the rules. That's why it's hard for me to answer when somebody says, well, Aetna in California, how do we code for such and for telehealth for them? They have a different set of codes, a different set of modifiers. Every insurance company has a different way of, say, doing telehealth. So you just have to know what their rules are, and when you bill, use those particular rules, and that will work. And probably what you want to do is create a cheat sheet. Just take a look at probably the 5 biggest insurers you have and create a cheat sheet for them for whenever you look at that CPT code, how are you going to bill it to that payer? So get a cheat sheet. That's the best thing to do. Question number 3, and I'm very specific about this question. RHCs bill Medicare RHC claims for RHC covered services using the following claim form: A, a 1500, or B, a UB04. And I'll give you just a second or two. And the answer is a UB04. No matter what, some of the people out there, I won't say their names, but you do have some companies, some billing companies or whatever trying to say, well, you're rural clinic, usually you have to bill it on a 1500 because you're in rural. No, you're an RHC under Public Law 95-210. You are required to bill on a UB04 for Medicare RHC services. And here it's basically, you're going to bill electronically. So nobody really ever sees a UB04 itself anymore. You're going to bill under what's called ANSI 837I for institutional format. It's actually a CMS 1450 is the actual form. And then if you want to click on this, there's an 8-pager telling you about an 837I format. For professional claims and for your independent RHCs, you're going to use a CMS 1500 for services that aren't covered under the RHC benefit, and we will show you what those are just in a minute. But here is for setting up your 837P format, the CMS 1500 form. Okay, RHC should charge only the RHC reimbursement rate. You're going to be given an AIR from Medicare and from Medicaid, so you should only charge them that particular rate. Or should you use the same charge master for all payers and then adjust the claim to whatever's paid? Or C, you should charge everybody the same charge master except for indigent patients, and you can do anything you want with that one. Or D, as much as possible, which is probably true, but it's not the right answer. So lock in your answer on this one and write down your answer, and the right answer is going to be B. You want to use the same charge master for everybody. Don't use the rate that Medicare or Medicaid sets for you as your charge to them. The only time there'll be an exception to that, I guess some Medicaid states, when you convert from your charging and your coding to billing, some states will require you to put that rate on there. If that's the case, that's okay. But for the most part, your charge itself should be based upon your CPT codes and your charge master. So, and here's just an example. Somebody's asking me yesterday, how much should we charge for a 99213? What I did was look at the Medicare fee schedule for this particular area. This is Palmetto. They were a Tennessee clinic. So we looked up the fee schedule that Palmetto provides for us, and the non-facility amount for 99213 was $85.59. So I took that number, multiplied that by 1.5%, and that gave me $130. If I used 150% of that number, if I used 200%, I got 170. So my recommendation, there's nothing magical about it, was I just split the difference and said, well, you probably ought to charge in the 150 range for a 99213, and think about what your local competition is doing and everything, and what do you think is reasonable as a fee for your services. But that's generally reasonable for that. So next question. RHCs are paid an all-inclusive rate which pays for all Medicare services provided to the patient while at the RHC. A, true, or B, false? Give you a couple minutes here to lock in your answer on your sheet of paper there. And the answer to that is false. Even though it says all-inclusive, sometimes the government really confuses you because they'll say these terms that they don't really mean. And this is one of these terms that they don't really mean, because all-inclusive is not all-inclusive. There's certain services that are not covered under this. There's lab services. You can build a Medicare Part B and get paid fee for service for it. If you're a hospital and you're a CA, you can get cost-based reimbursed for it. You have to use a different bill type for that. We'll talk about that. Amanda will be talking about that in the next session. But so lab, technical components of x-rays, your EKGs, those are not covered under the all-inclusive rate, so you can build those separately. Anytime you step in a hospital, that's not covered under the RHC services, so that would be something you could build outside the all-inclusive rate. Telehealth is not covered as a part of this, except for mental health. They've changed the rule just recently to where doing mental health via telehealth, you can get the all-inclusive rate for that. So that's something different. And your chronic care management and your principal care management, those things are not a part of this all-inclusive rate. So you can get that additional money. Shannon O'Neill talked about that in the session earlier this week, that chronic care management is now paying $81 per 20 minutes of time for that. And principal care management is $81 for 30 minutes of time for that. So those are not a part of that all-inclusive rate. So those are services you want to look into because they're going to add revenue to your bottom line. And again, the government sometimes drives you crazy. It says all the to be a rural health clinic, you are required to do 6 CLIA wave tests, but those aren't covered under the RHC benefits. So you can bill, even those 6 required lab tests, you can bill and get paid in addition to the all-inclusive rate. So again, that doesn't sound exactly logical, but that is the rule. Okay, to bill Medicare, RHCs must always have a face-to-face encounter. Probably from that first question there, you probably got a hint on what the answer to that one is. So I'll give you a minute or two to lock in, and the answer is false. You don't have to have a face-to-face encounter. First off, let me tell you what a face-to-face encounter is so you know what it is. Number one, an RHC, if you provide a medically necessary service or a medical service or a mental health service or a preventive health service where you have a face-to-face encounter, you're actually physically with that patient and you're seeing them, it has to be done by a physician, nurse practitioner, PA, certified nurse midwife, a clinical psychologist, or a licensed clinical social worker. It has to be within their scope of practice for that particular provider. That's a face-to-face encounter. That is something that comes from back in 1977. It's actually sort of an outdated concept with the way healthcare is done 45 years from that, but it's still in the manual. I always talk about Chapter 13. If you don't know anything about rural health clinic billing, there's about 47 pages or so on RHC billing in Chapter 13 of the Medicare Benefits Manual. As a consultant, people ask me questions all the time. I don't know what the answer to them are. A lot of times, I will refer to that Chapter 13 and give them a section of it. So if you're new to RHC billing, go to Chapter 13. It's really easy reading. Again, it's about 47 pages long or so. Half of it's related to FQHCs. FQHCs are not the same thing as RHC, so skip the FQHC stuff and look for the RHC stuff in there, and that will be that's going to be like a billing Bible to you, is to get the concept of how to bill. So that's a great resource for you. And then here are some of the examples, again, of services that do not require a face-to-face encounter. Telehealth, chronic care management, and principal care management. Those do not require a face-to-face encounter for you to provide those services. Number 7. For an RHC to bill an encounter to Medicare and receive the all-inclusive rate, the encounter must be located on the QVL, the Qualified Visit List. And so I'll give you a second to lock your answer in on that one. And the answer to this one is false. Here is the QVL. The QVL came out in 2016 when Medicare started requiring us to put HCPCS codes on the UB04. They changed the rules around and they said, oh, it'd be a great idea if we made this list of things that would qualify for you guys to get your all-inclusive rate. So we're gonna make this list up and we're gonna keep it up. That didn't last long. It lasted, I don't even think they put out 1/4 of a change to that QVL list, but it still exists out there. You can click on here and this will give you a good idea. This resource is a general guideline for what should be counted as an RHC visit. But what they did after that, they just said, you know what, that's really too hard for us to do this list. Why don't you just stick CG on there? Doesn't mean anything, but just stick a CG on there, and that's going to tell us that you want that to be paid at the all-inclusive rate. So that's what you pretty much have to do in order to get paid your all-inclusive rates now, is put in 99213 CG as your modifier, and that will tell Medicare that you want to be paid your all-inclusive rate. Okay. An RHC must include a CG modifier on all claims for RHC covered services. Give you a second to think about that one. I told you just now that it needed to be on claims, but does it have to be on all claims? I guess anytime you see all on a question, it's a lot of times that's a key that the answer is going to be false, because it is false. What it is when in 2016, when they started doing these rules, they gave a FAQ on how to use the CG modifier. And it's about 7 or 8 pages long, and I think there's 17, 18 different questions on there that they answer that. And if you bill an IPPE and chronic care management, you do not have to put the CG modifier on there. If you put it on there, it will probably, the claim will probably process okay, but it's not required for you to put that CG modifier on there for those particular claims. What I would do, this reference tool, go to it, print it off, and that way you'll know when to use CG, when not to use CG, because they give all sorts of examples of billing. Because what if you give a medical visit, a 99213 E&M code, and you do an annual wellness exam at the same time, or an IPPE? How do you put that on that claim form? Again, that's going to be a 201 session there that you can go over, but this will give you an idea of how to use your CG modifiers when you're billing. Okay. The MSP Player Questionnaire questions must be asked A, every visit, B, annually, or C, every 90 days. And give you a second or two to think about that one. You're probably not going to like the answer to this one, but this one is every visit. The Medicare Secondary Payor rules state that every visit you should be asking a patient when they come in, do they have black lung? Do they work at the Walmart? How many employees does that particular employer have? Is it 100 or less? Did you have an accident? This morning I was late on everything. I had an accident. My beautiful 2006 Tundra is no longer. I'm still bleeding from the wreck. But so I guess when I go in, they're gonna, if I'm a Medicare patient, they're gonna ask me these questions. Was your 6-inch gash in your leg caused by an accident? And I'm gonna say, yep. And they're gonna go to call Theo at Farm Bureau and say, you guys gonna pay for this. So you need to ask those questions every time. So, and that's one reason why I didn't get all my stuff done this morning. So I apologize. It was one of those mornings. Okay, so Medicare Secondary Payor rules. Though here's the link to go to the fact sheet. Anytime if you want to learn something about Medicare's very good about putting out these fact sheets. So if you put in Medicare vaccine fact sheet, you're going to get a beautiful fact sheet that will tell you exactly what you need to know. So in this case here, we pulled up the Medicare Payor Secondary fact sheet, and I copied this from that. Here is what these questions are on here or look like. Are you receiving black lung benefits? What is that one there? Government is BL is primary only for this black lung. Okay, and there's about 7 or 8 pages to this form. What you should do is reach out to your EMR provider. They should have some type of system within the EMR that whenever a Medicare patient comes, every time you're going to ask Mrs. Jones, did something change? Why are you here because of an accident? If they're here by an accident, you're gonna want them to fill out this form completely. If nothing's changed, you probably should have some little boxes in your EMR where you can check off that you've asked those questions to that patient. But there's, like I said, that's a 7 or 8 page document there that you're supposed to have every visit. So Medicare saves out of the $10 billion per year by finding somebody else to pay the claims. So they want you to do this every visit. CPT Category 2 codes cannot be included on a UB04. Give you a second there. What Category 2 codes are, those are quality measures, things like BMI and all sorts of different quality measures that you do. Value-based payers will pay you extra money for it. ACOs, like if you're participating in Charles James's ACO, the Medicare Advantage program that they, what's it called? RHC Advantage, I think is what Charles calls it. But if you're participating in one of those, can you put those category 2 codes on the UB04? And the answer is no, you cannot. It will not go in there right now. There is a registry that you can go in and put those codes in there. So that's something that you'll want to think about doing, especially if you participate in ACOs and quality measures like that. Question number 11, what place of service should an RHC use for billing Medicare? A, 72, B, 11, or C, the revenue code serves as the place of service service code on a UBO4. Give you a second or two to think about what the answer to that one is going to be. And the answer is on a UBO4, there's no place for a place of service code. So you would use the revenue code. So in this case here, we're going to chapter 9. Remember I said chapter 13 is your Bible. There's a New Testament and the Old Testament. The Old Testament is chapter 9. This will tell you exactly how to fill out these field FL. That stands for Field Locator 42. There's 81 field locators on a UBO4. Chapter 9 will tell you exactly what numbers, what codes to put in there. It has occurrence codes, value codes, incident codes. It describes what those are. It has the revenue codes in there. So go to chapter 9 to do your studying on how what revenue codes you should be using and how you're going to fill out that UBO4 form that you're going to have to fill those out. So this case here, most of the times you're going to use a revenue code 0521. That's going to be a office visit at your clinic there where you do a 99213, 99214. Trying to think. If you're at the, here we go. Here's one for, this is what I needed today. At the scene of an accident, if you were a kind nurse practitioner and showed up at the side of the poor man's house, that I destroyed this poor guy. I destroyed his mailbox. The story is I always take 2 cats with me every day to work. It's a 22-minute drive. The cats jumped out of their box. They went crazy. I went to grab the cats and I hit the mailbox and I destroyed the mailbox and my Tundra. So I'm very sad. So if we'd had a nurse practitioner, that'd have been a 0528, which I've never seen anybody do a 0528 before. But here are the different codes, things for nursing homes. If you go to a patient's home, you can do a 0522. These are for skilled nursing homes. 0525, that's for something that's a nursing home that's not a skilled nursing home. 0900 for mental health services. When you're doing telehealth and you're doing a mental health service for that, you want to use that revenue code because that's going to tell Medicare to pay your all-inclusive rate in 2022. Okay. This one's going to be fun. This is called negative reimbursement. And RHC treats a patient on January 1, 2022. Okay, we'll do today. On February 17th, the RHC treats a patient on February 17, 2022. They charge Mark $233. I'm a Medicare patient. I have not met my deductible yet. I've not gone to see any doctors so far this year. Our all-inclusive rate is $113. Probably said you didn't know there's going to be math involved in this session, but there's going to be a little math here. So RHC, our all-inclusive rate is $113, which is the max for 2022 if you're an independent RHC or if you're a provider-based RHC that's more than 50 beds. So when the bill is submitted to Medicare, how much is Medicare going to pay you? A, 0, B, 120, C, they're going to withhold $120 from your patients, or not from your patients, from you, or D, $46.60. And I'll give you a second or two to think about that one because, like I said, there's math involved here. And unfortunately, the answer is going to be a negative 120. They're going to actually withhold money from you. This is from I think this is from the Palmetto website. I took their example and then I just updated the numbers to 2022. So in this case here, the deductible for 2022 is $233. Our all-inclusive rate is, we're getting the max, is $113. They're going to apply $233 to the deductible. They're going to expect you to collect that $233 from that patient. They're going to assume that you did collect it. And so what they're going to do is on your next EOB you get from them, instead of paying you any money, they're going to actually withhold $120 from you because they're going to say you were overpaid by $120 for that particular visit because you received $233 for it, and your all-inclusive rate was only $113. That happens January, February, March. If that patient has not met their Medicare deductible, that's going to happen to you pretty much those 3 months. You typically don't get any Medicare money until the second quarter of each year, just because of this negative reimbursement rule. So and let's see, I think we had a question on how to post this. So when posting a negative reimbursement claim, an RHC should always, A, ensure the patient balance remains correct after posting. B, you're going to post the withhold to the patient balance. C, you're going to enter that negative reimbursement on your credit balance report and report that to your MAC. And the answer is, I'll give you a second to think about this one. The answer is you want to ensure that the patient balance remains correct after posting. So once you post, it's going to say Mark Lynn owes you a deductible of $233. You're going to post the account to where I still owe you $233. Then whatever that difference is, you're going to write off as a Medicare contractual adjustment. You can't balance bill that. You can't take that from that particular patient or any other patient. That is a contractual adjustment that you have to write off. So ensure that the patient balance remains correct after posting. So post that already. That's the easiest way to do it. You have this weird thing called how often, it's called a Form 838 credit balance report. If you do not fill this report out, Medicare is going to cut your payments off, and it happens all the time to new clinics. They don't get the message. I know we try to tell people all the time that you got to do this 838 credit balance report, but sometimes I don't think they listen to me. But so how often does this RHC Form 838 credit balance have to be reported to your MAC? Is it weekly, monthly, quarterly, or annually? And I'll give you a second or two to think about that one. Lock in your answer. The answer is quarterly, every quarter. Think about your 941 tax forms, January, February, March. They're going to be due April 30th of the month after that. Same thing with this quarterly 838 report, this credit balance report. So fill those things out. You can typically, they take about 5 minutes normally to do for a rural health clinic because you don't have a whole lot of credit balances. If you do, you're gonna handle it through an adjustment through your claim system. So you'll want to fill out this Form 838 credit balance every quarter. Otherwise, your payments are gonna get cut off. And here's what the form looks like. Here's where you can click on CMS. You can download that from them. Your MAC will have a fax number you can fax this to, or they may have a portal where you can actually do that. So a MAC, if you don't know, is the Medicare administrative contractor that pays your bills. So, okay, 15. We're getting close to the end of our questions here, and we're doing good on time. Influenza, pneumococcal, as well as COVID vaccines and MABs in a rural health clinic, how are they paid? Do you put them on the cost report log? Do you bill them on the 1500 on a UB04, or do you bill them to Medicare Part D? And so those are our choices there. Give you a second to think about that one. And I'll go ahead and answer it. The answer is going to be A. You're going to put it on a log. You should have a log that says Medicare, the patient name, their MBI number, used to be called the HIC number, that's their Medicare beneficiary identifier, should go on there, and the date that you gave them the flu shot, the pneumococcal shot, the COVID vaccine, or you did the monoclonal antibody treatment for that particular patient. So put those logs together. One key thing to remember is for 2021, you're going to put the Medicare Advantage COVID vaccines and MABs on that cost report as well. That's just for COVID vaccines and MABs. You can put Medicare Advantage patients on that. Then that's weird. That's never happened before. For 2022, you will not put Medicare Advantage patients on your COVID vaccines and your MABs on the cost report. So that will go back to the normal way of doing things. You never put Medicare Advantage patients for influenza and pneumococcal on the cost report. Those are handled by that Medicare Advantage plan. Okay. 16, to bill for RHC services, a new RHCs needs the following: A type 2 institutional MPI number, B, a CCN or PTAN number. We tend to use those interchangeably from CMS. You have to have what's called a tie-in letter. C, you should have to have an all-inclusive rate that's going to be set by your MAC, your Medicare Administrative Contractor. And you should have a submitter ID for electronic filing. You may, your EMR company should have that. Azalea should work with you to get that if you're using Azalea. If you're using a clearinghouse, that clearinghouse will have that. So you'll work closely with them to get your submitter ID set up so that you can electronically file your claims to Medicare. And the answer is going to be, give you a second here. I think this is going to be pretty obvious. It's going to be E, all of the above. You're going to need all of these to start billing. And that's one of the things that we always talk about, going through the trough of disillusionment, because you become an RHC, you come out and you're surveyed on February the 17th, and you're expecting to start getting paid from Medicare and Medicaid, all this money like manna from heaven the next day. Unfortunately, it normally takes about 2-3 months before you get all of these 4 items set up, before you get your Medicaid enrollment going. I mean, it takes a long time. And so you're stuck holding Medicare, Medicaid claims for that long. So we always tell people, get a line of credit for the trough of disillusion, because you're gonna be running out of cash pretty quick if you have a lot of Medicare and Medicaid that you're holding claims for. This is what the tie-in letter looks like, and we're sort of dependent on your CMS to get these tie-in letters out quickly. I know that we're in the Atlanta region for the most of our clients. They tend to get them out very quickly, although here recently they slowed down a little bit. But you have a one-page letter. I don't know why it takes so long. It's a one-page letter where they assign a number. They give you the date that you were inspected here, December 21st, 2021. They assign you a MAC, and Palmetto GBA is the MAC for Tennessee, Alabama, and Georgia, and that's what's called in jurisdiction. That's the jurisdiction for them. You will see Palmetto be your MAC because they're what's called out of jurisdiction MACs for a lot of you guys. And the reason why, in 2009, before 2009, Riverbend GBA here in Chattanooga was the MAC for about 30 different states. When that transferred over, that contract went to CAHBA, and then CAHBA lost that contract and went to Palmetto. And for some reason, they've never, CMS, again, your government does weird things, they've never transferred those out of jurisdiction MACs to the proper place. You know, if you're in Indiana, they need to be going to WPC, and if you're in, you know, so I don't know why they've not done that, but that's why you're having out of jurisdiction MAC if you're in one of those weird states. Here's the rules on the submitter ID, the manual here. So, and the government sometimes they get ahead too. This one here says it's for June 3002. So I don't think I'm gonna be around for that one. But there's the rules for submitter IDs as well. 17. We're an independent RHC and we have non-RHC hours. Can we bill the non-RHC services with the same NPI number? And because what we have typically told people is you just need one NPI number. We can use that same number that you've always gotten. We don't want to get you a new one, because that type 2 NPI number, we don't want to credential, re-credential a lot of different providers with that. So give you a second to answer this one. Probably from the way I was talking, you probably figured out that the answer is no. If you're going to set up non-rural health clinic time, you have to get a separate NPI number that's billed, that's credentialed fee for service. I think you have to do an 855R maybe, you do an 855B and then an 855R in order to do that. This all came about, used to it worked great until July 1 of 2021 when CMS came out with some new edits and I haven't seen any other MACs implement this edit. I just haven't seen it. I know Palmetto has started doing this edit, and we've had a lot of clinics getting claims rejected because of these particular edits, and it was because of this particular issue. So if you're getting your stuff that's billed to Medicare Part B rejected, and you really don't think they should be, one way to possibly fix that is to get an MPI number, get an additional MPI number, get it credentialed with using your 855B, your 855R, and then that should work if you're having those issues. Of course, that's a long process. I don't think we really should have to do that, because Medicare knows if you bill it on a 1500 form, let's say you're an independent RHC and you bill something on a 1500 form, they should know that you're asking for fee for service for that. And we're not going to put that on the cost report as an allowable expense. We're going to actually pull that out. So these new edits have caused all sorts of problems for RHCs, at least the ones that I know have Palmetto, it has been that way. 18, last question, hallelujah. How are we doing on time? Yeah, we're doing good. RHC telehealth claims are currently paid as follows. A, at the all-inclusive rate, the AIR, or B, at a fee-for-service rate of $97.24, except for mental health services in 2022, which are paid at the all-inclusive rate. And give you a second to think about that one. The answer to that one is going to be B. Right now, the rule is you're going to get a fee-for-service rate for telehealth services, except for mental health services. And this is going to cause us a problem on our cost reports, because we're going to need to know if you got paid that all-inclusive rate for mental health services. We're going to have to include that as a visit in our visit counts. While if it's a telehealth visit and you're paid fee-for-service, we do not count that visit in our visit count. So keep up with those visits so that you don't overstate your visit. I know a lot of people, I know I was reviewing a cost report that somebody did yesterday, and their cost per visit was ridiculously low. And I could tell they had counted their telehealth visits in those numbers, because their telehealth visit numbers were way high, and all of their visits were really, really super high. So they had to include that. So we're doing some work on that. So just keep up. It's not always a great thing to have a lot of visits. Now, a lot of people think, oh, the more we have, the better off it is. No, that makes it harder to get your cost per visit up higher. We want to be accurate, not the most you can. So, okay, so that's your questions. I don't know we'll find out how everybody did. If you want to put in your chat how you did, and that will be great. We'll take a look at those later on to see how everybody did. Here's just some reference materials for you guys. Here's our website at ruralhealthclinic.com, RHC Billing. Once I get everything together and get my car, get another car around, I missed my 2,600 already. But we will get this updated with recordings and slides and all this. This is going to be our billing section here. And then if you haven't joined the National Association of Rural Health Clinics yet, do that. They're having a meeting in March 2022 in San Antonio. You can go virtually. That's where you're going to get a lot of education. There's a lot of great speakers there about billing, so you'll definitely want to do that. And you can join up and do the Certified Rural Health Clinic Professional Program and take the test down there as well. So that will be great for you guys. Here is the RHC fact sheet that I talked about earlier. It's 11-pager that was updated in January 2022. Print that off, study it. There's going to be sections in red of things that have changed in there. This is called the Rural Health Clinics Center. This is by CMS. Bookmark this page because things change. The spotlights section here is pretty long. It tells the updated information related to billing. Some of this billing information is nowhere else in any of the MidLearn Matters that you get. The stuff on mental health billing is in here. That's the only place I've ever seen it is in there. So you'll want to bookmark this for things that change, especially during the pandemic when things have changed pretty quickly. So you want to, that's something we look at. And here, this is the second page here, you can see all sorts of things here. If you want to get a listing of all the Medicare certified RHCs in your area, and we use that for your emergency preparedness manuals to see what RHCs are close to you, you can click there, and there's something called QCore. And QCore will list that as all sorts of information in there. One of them is what deficiencies are found in RHCs in your particular state or nationwide. So you'll know what the surveyors are looking for. So QCore is an invaluable resource for you guys to look up information related to rural health clinics, especially related to deficiencies. This is a 43-pager from CMS on rural billing. So if you're a hospital, this is a great document because it has all the different services you can provide. Hospitals, SNF, home health, all those sort of things are in here. There's about 5 pages related specifically to rural health clinics, pages 24 through 28. And if you will go through those, it's based upon, it's in chronological order here. So not chronological, what is it? Alphabetical order. There you go, alphabetical order. So it tells you what service they're talking about, what the billing information related to it is, where to get more information here. You can click here about copays. You can click here, chapter 13, chapter 9. Remember, that's our Bibles for billing. So they're showing you where you can go to that. And I just put another random one in here about how to do this. Here's how we do our flu and pneumococcal. You put it on the cost report. Wow, Mark got that one right. Hepatitis B, that one you just sort of, you don't really get anything for. That's what we want. That's what we call Incident 2. We'll talk about that in a 201 session. My country way of saying it is Incident 2 means you ain't getting paid. So I know people don't like for me to say that, but that's really what happens is you don't get any additional money for Incident 2. And then your IPPEs, medical and nutritional therapy, you don't get, that's an Incident 2. You don't get paid for that either. So MedLearn Matters transmittals. Every so often, Medicare will put out these transmittals that will tell you how to bill. Like the new information on hospice, when you can now bill for hospice services in 2022, there's a GV modifier. They explain to you how to do that, and they'll go through, and about every month or two, they'll have something new. So you want to bookmark MLN Matters transmittals and review that every so often so that you know what's going on there. Noridian, which is one of the MACs, has a really good billing guide. This is probably 9 or 10 pages long. Little warning, there's probably 3 or 4 things that are wrong in it in looking through it, but for the most part, it's going to get you in the right direction of that, so of information there. And then you really need to know your MAC. Your MAC is your Medicare Administrative Contractor. What you want to do is make sure you get the right MAC, which jurisdiction. So rural health clinics, they typically use jurisdiction J. And so you want to double check that because Palmetto, they have contracts with different jurisdictions. Novitas, they have different jurisdictions. So you could be sending information to the wrong address, to the wrong credit balance report. And that's where a lot of errors happen in your clinics is you say, oh, I sent that, I faxed that to the right place, but no, you faxed it to Novitas for Pennsylvania, not Novitas for Louisiana, Texas, or whatever. So watch those jurisdictions there. Make sure you know your jurisdiction number that you're in and send stuff to the right place, the right MAC contract, because that's something very confusing to a lot of people, and it can cause you problems. Palmetto has a very nice little service here where you can go in. If you click on here, all these are clickable links. It tells you how to bill these particular services, so you can get to it very, very quickly. And then the RHC Information Hub is something that has a lot of FAQs in here, a lot of great information, a lot of technical assistance as well. Also, the National Association of Rural Health Clinics, that's technical assistance, phone calls all the time. Nathan Baugh, Bill Finner-Frog, Sarah Holman, they do a great job in telling people about what changes are for rural health clinics. So this is a great service as well. So, okay, I finished up in only 4 minutes longer than I anticipated, which is not terrible for me. So, Danny, do we have questions?
Yes, sir.
Oh boy. I'll do
No, there's not that many. We did have one person ask for clarification on question number 10, and that one was when you were talking about CPT category 2 codes. Can you go over that one more time?
Yeah. Question 10. Let's go here. Question 10. Where's question 10?
Slide 35 if you need it.
Okay, I'm almost. CPT code category 2 codes cannot be included on the UBO4. They cannot. They cannot. I tried to look up the reference for that. I could not find it yesterday. So, but that's true. I know Peggy Harper's. I know she always explains there's some kind of registry that you can go into, and so and you can put that information in that registry and submit it. I don't know how to do that. So Patty, maybe that's the way you would need to do that. Okay.
Okay. Vicky asked, where can we verify the amount is correct for the 838 quarterly credit balance report?
Where can we verify the amount is correct?
She might be asking where she can find that. And your billing company would be able to help you.
Yeah, Vicky, you're in Novitas, so what you want to do is make sure you go to the proper Novitas Mac website and then just type in 838 credit balance report. I think Novitas may have a portal where you can actually enter it in there, and it will tell you if it's in there or not. I know that's the best thing you do on that.
Okay. Louise asked, so the non-RHC hours, is that different from the non-RHC covered lab and technical components? I think that question popped up when you were talking about that second NPI number.
Yeah, and that is a good question. Louise, that's a really good question. Non-RHC hours is definitely different than like laboratory. Laboratory, you are quite required. Medicare it's a big deal about commingling. They're like, they don't want you to commingle, but then they make you commingle for non-RHC services, things like technical components, things like laboratory, things like hospital services, and the cost report is set up to handle that. So what you want to do is you're supposed to be able to bill those fee for service, use the same NPI number, bill it on a 1500 if you're an independent RHC, and get paid that, and it shouldn't be a problem. What's non-RHC hours is when I say on Wednesday, I know we had this one clinic in Indiana one time. On Wednesday, what they did is that they were non-rural clinic all Wednesday, and they scheduled all the trigger point injections, their IPPEs, their annual wellness exams. They did all of this stuff that took a long time, and they would bill it Medicare fee for service during that particular time, and we would exclude all the costs related to Wednesdays would be pulled out of the cost report, and we wouldn't count those visits. What Palmetto is now saying is if you do that, and you use the same NPI number as you did before, we're going to reject every single one of those claims. You have to get a new NPI number and credential that to Medicare Part D fee for service and use that different NPI number. And unfortunately, what I've been seeing is a lot of services like lab and EKGs are getting rejected for those claims. They're actually, or those edits are catching those, and they shouldn't be catching those. So, okay. Let's see here.
A lot more coming in. Can you clarify the statement about not counting the telehealth visits in the visit count for the cost report?
Yeah, for telehealth visits, for 2021 cost report, what you want to do, you want to keep up with them. You want to tell your cost report preparer, the number of visits, of telehealth visits you had. So if you had 1,000 visits, what we're going to do as a cost report preparer is I'm going to take 1,000 visits and I'm going to make what's called a reclassifying entry. I'm going to reclassify it to line 79 of the cost report, and that's going to disallow that expense for that. So we need you to keep up with it and tell your cost report preparer what those are so you can disallow that cost, because you're paid a fee for service for that. So that doesn't get counted in your all-inclusive rate. So that's I think that's about as clear as mud as I can get. So
okay. I'm having a hard time with the Medicare Advantage plans. When do I treat them as commercial plans, and when do I need to bill as if they are Medicare Red, White, and Blue? Can you touch on this a little?
Yeah, I was saving. I didn't want to deal with that because Medicare Advantage plans they're just like commercial insurances. They have their own rules. It's the golden rule applies to them. So you want to, however they want you to bill is what you want to bill. Now, if a patient is original Medicare, then they're going to go on the RHC. They're going to show up on your PSNR report, and you're going to bill them as an RHC. But a Medicare Advantage plan, it's not going to be an RHC service. Now, there are ways where you can actually get your rate from them, and there's certain types of Medicare Advantage plans that are required to pay you your rate, but you have to work with them on an individual basis to figure out what they are and how you should be getting paid. That's a little bit over the scope of what today's session was about. Okay.
Okay. Where do we find out what jurisdiction our clients are in?
Probably if you just Google everything. If you just Google CMS, Medicare Administrative Contractors, you're going to get a listing of who the different MACs are and their different regions that they're in. Now, the only problem is those out of jurisdiction ones are not going to show up in there, and that's a little bit confusing. So a lot of times you just have to ask your client, who do you bill RHC services to, because we have them in Indiana, we have them in Kansas, and they're all going to Palmetto, and that's out of jurisdiction. They shouldn't be going there.
Okay. For telehealth, are we no longer billing G2025 to RHC? It now goes to Medicare as an office visit for independents. When did that become effective?
No. Well, you're getting your coding and your billing mixed up. Your coding is still a 99213, but your billing is a G2025. So you're still going to be billing. You're still going to be billing the G2025 for telehealth. See, that's why it's so confusing. Is those issues right there. So that hasn't changed. Your telehealth services are still going to be a G2025. The difference, the only exception is going to be mental health services. Mental health services, you're going to use a revenue code 0900. You're going to use that HCPCS code that describes those services. It's like a 907 something. So there's like 6 codes that are mental health service codes. You're going to put that code in there, and then Medicare is going to pay your all-inclusive rate for that. Okay.
All right. Going back to the non-RHC visits, should the RHC not be doing wellness visits for Medicare and Medicaid?
Should the RHC? No, yeah, those are covered. Those are a covered service for rural health clinics, so you can do them. What used to happen was, because the Medicare rates were so low, a lot of RHCs would schedule those during non-rural health clinic time, because an annual wellness and an annual wellness and an IPPE, you would get paid, $150 for those, versus you get paid $60 as a rural health clinic, because your cap was $86.31. They'd pay you 80% of that, and they would just schedule all those, because they would take 30, 45 minutes to do those. They would schedule during non-rural health clinic time. That problem is going to go away in the future when our rates keep getting higher and higher. And right now they're up to 113. They've jumped from 86.31 to 113 over a little bit over a year. So and they're going up $13 a year going forward. Okay, next question.
Okay. In PayCodes, do you have to have the providers working in the RHC reassign their benefits to the 855A application approval for them to receive the RHC rate, or will the CG modifier just signify the correct reimbursement?
Yeah, you do not have to do all that, the 855R in a rural health clinic. It basically, the way the RHC billing works is you're going to have that type 2 MPI number. You're going to put that type 2 MPI number on, it's in field locator 56 of the UB04. So that's going to be your first place. And then in field locator 76 is going to be the attending. And you're going to put the MPI number of the attending nurse practitioner, PA, or physician in that place. And if you put the CG modifier in field locator, what is it, 44, 42, 43, 44, and put the proper revenue code 0521 in field locator 42, your claim is going to process. So.
Okay. We used our corporate MPI for our application. It sounds like we should have obtained a different MPI. This was the first I heard we need a different MPI. This will be a problem. Corporate is what we use for the clinic for Part B.
Well, I mean, if you've got two different MPI numbers, is she saying, Danny, I'm misunderstanding. Is she saying that they have two different MPI numbers already?
It sounds like they just have the one corporate MPI that.
Yeah, I have only seen Palmetto causing a problem for this, and it's only supposed to be for non-RHC hours. So if you don't have non-RHC hours, it shouldn't affect you. What I would do is just see what's happening in your billing and just pray that you don't get caught up in it. Because like I said, I don't know. And if you guys are different MACs besides Palmetto and having this issue, let me know, because I have been working with CMS now for 7 months or however long it is, 8 months now when this first started happening. And we're trying to tell them this is wrong. You shouldn't be doing this. But they keep saying, no, we're right. This is the way it should be. So next question.
Okay. Are telephonic encounters considered telehealth, and should we keep up with those numbers?
Absolutely. Yes, those are considered telehealth. And you'll want to keep up with those. We're going to exclude those from the cost report. The way the cost reporting, or the way telehealth works, is there's a listing of about 206 different things that you can do via telehealth. There's an Excel spreadsheet that CMS provides for you. Go through that, but there's telephone only was added to that. That's like a 99441, 99442, 99443. Those telephone only visits will get paid your 9726 or whatever that number is as a telehealth visit.
Okay. The other one, the last one I see is it a good idea to bill all Medicare follow-up visits as RHC visits on a UB04 with the CG modifier, or is there something that keeps us from doing all visits like this?
I don't really understand the question. All follow-up visits. I mean, you have to meet the criteria for a face-to-face encounter, which is a face-to-face encounter between a physician, nurse practitioner, and PA, where a medically necessary service is provided within the scope of practice for that particular provider. If you've met that bar, then you can count that as a visit. You don't have to worry about, globals or anything like that. There's no globals in rural health clinics. So if that's the question, yes, those will continue to be visits. It can't be nurse-only visits. There's no 99211s in as far as billing Medicare in an RHC. So if you have a nurse that sees a patient, then you're not going to count that. So.
And Mark, she also typed in and said, does it depend on DX?
Diagnosis? Yeah. Probably not. I mean, I haven't seen clinics get denied for medical necessity based upon that since, I think, Riverbend, or it's been a long time. Used to, when you would do what is that drug? There's warfarin or something like that. When you have INRs, when you do INRs and nurse practitioner would see them, they would say that was not medically necessary for a nurse practitioner to see that patient at that frequency, and they wouldn't let us bill that as a rate. But that's probably been 15 years ago. Last time I've seen them deny something based upon diagnosis.
Okay.
Oh yeah, one question. Are the cats okay? That's the most important thing. And Louise, yes, the cats are just fine. They were a little bit upset that there was actually what messed me up this morning was I had a can of tuna that was opened on my gear shift, and it sort of moved around, and I think they jumped up to see that tuna, and then I reached to grab the tuna can and hit the mailbox. So fun morning. Okay.
Mark, I have one more that came in. You got time? Yeah,
one more time, and one more, and then we got to go.
Okay. I heard She said, I heard the question about the annual wellness visit being billable in the RHC. We are having issues with denials because we are flipping G0438s and 0439s to telehealth codes G2025. It's being denied for invalid diagnosis. Are you saying that we have to declare non-RHC hours to charge those out?
I'm not sure about that question. You shouldn't, but I think I've been seeing that question show up in a lot of things, and I meant to take a look at that this morning just because I thought this question might be asked, and with my car wreck, I didn't have time to look at it. So that's more of a 301 or 201 session. So we'll address that at the next session or the one after that. And we will keep these questions here. I'll go through them and we'll get some answers for the next. The good thing is with all these sessions, we can come up and address some of these questions as we go along. Okay. Okay. And yeah, I think that's good. I've got to run here because I got some. Yeah, I got all sorts of voicemails coming in because of the wreck today. So I got to talk to insurance companies. Thank y'all very much. We appreciate it. Thank y'all. Thank you for what you're doing. Danny, thank you. Have a good vacation. And we will talk to you guys next week. We'll talk to you on Tuesday when Amanda will give us some more information. So thank y'all.